Good morning, class. It's good to be back for another session, and I will be your presenter for today. I hope you have all established your study technique and are progressing nicely on the course thus far. Today we'll be continuing with the medical emergencies that you have started, and we'll be covering 3 chapters today, and we're going to begin with psychiatric emergencies. So psychiatric emergencies are situations where the patient is going to be having some behavioral crisis, and so with these calls you will be called upon to use all of your skills that you have been taught as a EMT, and especially a big focus will be on scene safety, and also you'll be using your communication skills a lot, and at the end of the day you will be ensuring that you have completed a proper documentation. So these are situations patients having behavioral issues, and we are calling them psychiatric emergencies. So these emergencies can be caused from a lot of things, and so you should not have a tunnel vision. So it can be from acute medical situation, can be from a mental illness, can be a mind altering substance that is causing the problem, can be from stress and many other causes. So again, as I said, don't have a tunnel vision, carry out your assessment and take it from there. So there are some myths and realities that we need to recognize when it comes on to persons having these behavioral crises or mental illness or psychiatric emergencies. So all of us at some point will experience an emotional crisis. This does not mean that everyone develops mental illness. All of us, and so even as an EMT, as an EMS provider, we'll be exposed to stressful situation which can affect us. That doesn't say that all of us gonna have a mental issue or a mental illness. So do not jump to conclusions concerning these patients or even ourselves or your co-worker, your partner. So be objective and do your assessment, and you can take it from there. So another myth that we have around is that if you are feeling bad or depressed, you must be sick, or some person take it further and say you are mad. But in reality, it can be from a justifiable reason. And so if you hear of a bad news, someone lose their job, they have reasons that they will behave depressed or they will become stressed out, divorce, death of a relative or friend. Several situations can predispose a person to be depressed. Again, that isn't to say that the person is mad or having a mental illness per se. So be aware of this situation, and again, we won't be judgmental. We have to be aware of these situations. So another myth that we need to realize is that most persons believe that once a person is having a behavioral crisis or a psychiatric emergency, then that person is gonna be having will be dangerous, violent, or unmanageable. It is a fact that only a small percentage of the persons fall in this category, but what will happen because of the situation where most of the time when we'll be called to a case of that nature is when the person has in fact become unmanageable or dangerous or violent. So in effect, a greater percentage of the persons that we will be called to with this situation will be on the violent side. So, but not to say that everyone that is having a mental health disorder is actually violent. Statistics show that is just a small percentage, but we might be exposed to a greater percentage because of the fact that they'll be calling us when they are out of control. If they are manageable, then more than likely they will take them to the hospital themselves. So many people believe, again, that that's the case, but communication is key. And so as an EMS provider, as an EMT, we are going to try to de-escalate the situation verbally. So we're going to try and talk them down. And you are going to be able to do that if you develop trust with that patient. So again, don't be judgmental, don't write them off. Just be empathic with them and try and get them to that point they can trust you. And that will work in some cases, not all, but that's the first approach we will try to verbally de-escalate the situation and be able to watch for violence. So again, it's potentially possible for them to be violent, and so you will have your situational awareness. Be focused on that. We said the first thing gonna be safety on these calls. Ensure at all times that you are always aware of your situation, because a case may be not violent at the outset and it can develop into a violent situation. So you may have at all times be mindful of your situation and have that situation awareness of the fact that violence can be there at any time. So you will have to be able to look at your patient, their activity level, their speech, and again we say you'll be called upon to use all of your assessment skills in dealing with these patients. So when we look at behavioral crisis, what is a behavioral crisis? So a person will be stressed out, they will be having a situation, they might behave what we call not how a person recognize them, society respect behavior in a certain respect, and so they'll be presenting with these abnormal behaviors, and so it's going to reach a proportion where they become unmanageable or stressful situation persists for a long period, over a month, and then that's when it's going to be called a behavioral crisis. So it says here, behavior is what you can see of a person's response to the environment, his or her actions. So most time people respond to the environment in reasonable ways. That's what society would rate it as being normal, what is accepted as normal behavior. But over time, people will learn to adapt to stress. So the problem is not that stress is harmful. You have good stress and you have bad stress, but it's how persons respond to the stress which will determine how it affects them and whether they are able to cope with it or they are being overwhelmed. And once they are being overwhelmed by it, that's when the behavioral crisis will develop. So sometimes stress is so great that the normal ways of coping do not work, and so you will have this behavioral crisis developing. So behavior is what you can see of a person's response to the environment, his or her actions. Reaction to stress that are acute and those that develop over time can. So one stressful situation can overwhelm a person and they have a behavioral crisis. But they say that stress is cumulative, so it builds up over time, and so a person is exposed to the stress and it keep on being exposed, and over a period of time they are overwhelmed by it, and it also be a behavioral crisis or a psychiatric emergency. So it can be an acute situation as well as it can develop over time. So as we said before, the behavior will reach a point where the person become unmanageable, they become violent, they become uncooperative, they are behaving in a certain way that society doesn't accept as normal behavior, and so that's when EMS providers will be called. Either the patient themselves recognize what is happening and they call for help, or most of the time it's gonna be family members recognize that this is not accepted behavior, or the community recognize that the person is behaving a way that is not the normal behavior, and so they are gonna call EMS and we will be called at that point. So it's when the crisis behavior has reached a proportion that is way out of normal accepted behavior, and society is what they're gonna use to judge behavior patterns or the culture. If you are living in Alaska and you wake up every day going out without shirt, person's gonna look and say that's not normal behavior, so they're gonna want to check you out. So it's what society judge as normal behavior. Once you are deviating from that to the excess, then they are gonna say that's behavioral crisis or a psychiatric emergency. So a patient may have a dementia or depression that interferes with activities of daily living, and that's a word phrase you need to keep in mind: activities of daily living, ADL. So that's what society accepts as normal behavior, are the behaviors that you need to maintain activities for living. So if you are not conforming to those, then you're gonna be in a situation where you're having a behavioral crisis. And a person who is having dementia or depression will usually be affected in their activities of daily living. So chronic depression, persistent feeling of sadness and despair may be a symptom of a mental health disorder. So a person, as we said before, even us as EMS providers, we might be stressed out, we will feel sad, but once this behavior is not gonna persist beyond a month, is what they use it to judge. Beyond a month, then that's when they're gonna say it's developing to a behavioral crisis. So yes, we grieve and yes, we feel sad and despair, but we do it and we get over it, and that's all right. But when it becomes that you're constantly having this persistent feeling of sadness and depression, then it's gonna be a chronic issue developing, and that is what they say will be a symptom to say that this person is having a mental health disorder. And again, the person who might be the ones to recognize it and call for help or seek help, but most of the times family member and the society or the community will recognize it and call for the help for the person. So as we look at defining behavioral crisis, if an abnormal or disturbing pattern of behavior lasts for a month or more, it is a matter of concern. So when a psychiatric emergency arises, the patient may show agitation or violence, may become a threat to self or others, and the word there is may. So we say it's a small percentage will reach that stage, but most of the time we are gonna be called to persons when they reach that stage. So as EMS providers, we might be exposed to more cases of those situations, but a person can have a behavioral issue, crisis, and they are not violent. So we need to recognize that. So what's the magnitude of this mental health disorder as it relates to our society? So as we are rating, these are based on US statistics, but it says that affecting tens of millions of people each year. And I am sure in Jamaica, we can say we have our fair share of mental health disorders. So it's a psychiatric disorder. It's an illness with psychological or behavioral symptoms that may result in impaired functioning. Anxiety disorders are among the most common. So a lot of things can cause this, and so we need to recognize that it's not strictly a mental issue only. It can be a medical, can be a drugs that is affecting the person, mind altering drugs, but most of the time it's an anxiety disorder are the most common. So stress is a big thing which will affect these persons, and so we will be looking further at them. So what are anxiety disorders? These include generalized anxiety disorder, panic disorder, social or other phobias, post-traumatic stress disorder, and we need to recognize that that is also a key factor there, and obsessive or compulsive disorder. So all of these can set up a person to be having these mental health disorders, and so we have to take them into consideration. And again, don't be judgmental, just be empathic with your patient and recognize that it's not they are not the ones who create these things on themselves, and so we need to be there to help them in their situation and know that it is can be a sickness, it can be a medical issue as well as a mental issue. So do our assessment at all times, do your assessment, and then you can know how to proceed with your patient. So the US mental health system provides many levels of assistance, and in Jamaica we might not have all of the levels to the extent that we would want to, but you will have professional counselors available. So at the lower end of the scale, you will have counselors can talk to the person and try to get them to that point where they can get over the anxiety disorder or the mental issue. But if that doesn't work, then they have to take it to the next level where you have a psychologist which will understand more about behavioral issues and can help them at a higher level. And if that doesn't work, then they will have to go to a psychiatrist with more severe psychological problems. So psychiatrists would have more experience or more training to deal with that sort of mental health disorders. So know what is available in your jurisdiction and seek the best help for the patient. But at the end of the day, we'll try to bring them to a facility that is capable of dealing with these disorders. So most psychological disorders can be handled through outpatient visits. Some people require hospitalization in specialized psychiatric units. So in Jamaica, you have Bellevue, you have the psychiatric unit at the University Hospital of the West Indies. So again, know what's available, but depends on where you are in Jamaica when you have that emergency. Most of the time, we'll just take them to the nearest hospital and see where they can get the help from there, and hopefully they can get the best help available. But it's all about what's available in this jurisdiction that you're in will determine what's the best help they can get. So these are situations where we must recognize that mental health disorders can have many underlying causes, and that is why we say you cannot be judgmental. So a person can be having a social or situational stress, and we mentioned that before. It can be from divorce, death of a loved one, loss of your job, bad news, changes in their lifestyle. It can affect a person to that point that it overwhelms them and they have the psychiatric or behavioral emergency. It can be from a disease such as schizophrenia. So it is also can be a mental issue as well as a medical issue. So physical illness such as diabetes emergencies can affect that person. It can be from alcohol or drug use. It can be from mind-altering drugs that they are taking, Ptsd and so forth. So be aware of that. And it can be from biological disturbances such as electrolyte imbalances. So we must recognize that it's not just to say that everybody having a mental health disorder is what we would say mad or psychotic or definitely having a mental illness. It can be from medical issues. So again, ensure that you do your assessment properly and take it from there. So as we are going to look at the pathophysiologies, problems that will occur which lead us to be called for these behavioral or psychiatric emergencies. So recognize that it's not our job in the field to diagnose the underlying cause. It is not our job to seek out and to find exactly what is happening. We will do our assessment, get our history and our vital signs, and it will point us in some directions that we will use to proceed with our treatment of the patient. But it is not for us to diagnose that underlying cause for the behavioral issue. So you should understand that there are two basic categories of diagnosis a physician will use. Either they are going to look at it as an organic problem or a functional problem. So organic problem is actually having to do with some physical change that is occurring, but functional one is where there is some mental issue that has affected how the patient is functioning, their daily activities of living, how they portray that. So it's not to say that they have a physical change in their body, but it's really of a functional issue. So with an organic disorder, the organic brain syndrome is a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or physiologic function of the brain. So there is some physical changes to the brain that give rise to this sort of disorder, which affect the person to have this mental health disorder or the psychiatric emergencies or the behavioral crisis. And causes include sudden illness, traumatic brain injury, seizure disorders, drug and alcohol abuse, overdose or withdrawal, and disease of the brain. So these are some medical issues that can affect the patient to predispose them to be having this mental health disorder or this psychiatric emergency. And so that's the way the physician will be looking at to see how they can diagnose and then see how best they will proceed with treatment based on what the diagnosis is showing. If it's an organic disorder, or it's gonna be a are you still hearing me? Raise your hand. Are you still hearing me, class?
Yes, sir, I can hear you now. Something happened just now. I don't know, but we're hearing you now.
Here
Okay.
now, here now.
Okay, I realized there was a break. Okay, so with organic disorders, it can be from altered mental status, from hypoglycemia, hypoxia, impaired cerebral blood flow, hypothermia or hypothermia. So these are looking at medical issues. So a person who has blood glucose and low oxygen can set them up to have altered mental status. And these are the ones that we would know about, but recognize that a person is having a mental health disorder can be from a medical related issue. And so you must do your assessment and get your vital signs, get your history, and then you will see where it's pointing you to and see what you have to treat, because some of it can be controlled in the field. Some of the situation we will only have to de-escalate the situation, get the patient calm down, and take them into definitive care where they can have that treatment done. But always you need to check them out to make sure that you are not missing something that you can treat in the field. So a person can have impaired cerebral blood flow, which will set them up to have stroke-like symptoms, and they can have that behavioral disorder. And too cold, extreme heat can also set up a person to be having these altered mental status, which we will lead to say could be a mental issue or a behavioral issue when it is actually coming from environmental issue. So the opposite side of it can be a functional disorder. So it can be a problem with the brain that will cause a person to behave differently, not to say that there is any physical change to the person. So a functional disorder is a physiological disorder that impairs bodily function when the body seems to be structurally normal. So you don't see anything physically wrong with the person, but their behavior is affected. And so their activity of daily living, they'll not be acting normally. So examples include schizophrenia, anxiety conditions, depression, and we said before that a big one will be anxiety disorders. So stress can set up a person to be having all of these behavioral crises or psychiatric emergencies. So the chemical or physical basis of these disorders do not alter the appearance of the patient. So the patient will be looking normal as ever, but they are not acting right. And so we are going to be looking to say that that's a functional disorder, and that's what the physicians will be looking at and deciding on the best way to treat these patients. So at our level, as a basic level, EMTB level, you will just have to do your assessment, see if you can de-escalate the situation, get the patient to calm down, do what checks you can do to check out, verify it's not a medical issue that you can treat, and then at all times we'll be doing our ABCs, and then you will take it from there. So recognize that there can be some physiological changes occurring, and so you have to be mindful of it. So what are some of the myths we talk about, Mr. Johnson? Tell me one of the myths that we talk about as it relates to behavioral crisis, patient having a mental issue. Mr. Johnson. Go ahead, Mr. Johnson. Tell me one that we spoke about that we know about that persons have relating to persons having behavioral crisis.
One, sir. We never there for the early part of the class, and we kind of jump on late because rain fall, so me just get a chance. The part of me come catch was the part where I talk about the organic and thing the part. And the
okay,
functional.
So what's the difference with organic and functional cause of behavioral crisis? In your word.
Alright, so for the organic, it have to do with like maybe some chemical changes within the brain function.
Okay. So it's a physiological change which will affect the person so that they will be showing some changes in their physical status. So okay. All right, Mr. Manning, you had your hand raised. Give me an example of one of the myths we spoke about regarding these patients with behavioral crisis.
Yes, sir. Morning again. So one of the myth, if a patient or a person is having a sad time, like they're sad or they seem depressed because of either death or losing a job, persons may think that they have mental issues, that they're mad.
Okay, thank you. Mr. Shantilope, give me another myth that we have regarding persons having behavioral issues or psychiatric emergencies.
Well, one of them could be loss of job or a family member. Even promotion.
No,
Speaking of job.
no, that's not the question. The question is there are some myth going around which is not reality, that patients who are having a psychiatric emergencies behave a certain way. So I'm asking you for another one.
Stress, sir.
All right. Mr. Wilson, can you give me another myth? Thank you, Mr. Manning. Mr. Wilson, can you give me another myth regarding these patients with psychiatric emergencies. We mentioned at least 3 of them.
Sir, I'm kind of joined late, so nobody catch the part. The beginning of the midst. Nobody catch the midst part.
Okay.
Start
Okay.
from.
All right. So you see, you need to be. You see the importance of coming on time. So make sure you read up on that, or you look on your recorded session. Okay, who else can give me another important myth that is out there that is not reality regarding these patients? Miss Rochelle.
Yeah,
Miss Rochelle? Okay, Miss Rochelle. Who can give me another myth? One important. Go ahead, Mr. Powell.
Mr. BNZ, sir, good morning.
Yeah, go ahead. Good morning.
Yeah, so one myth is that people that are experiencing mental changes are violent and uncontrollable.
Okay, so the myth is that the myth is that they are saying that most of them are violent and uncontrollable and manageable. But the reality is that is not most of them, it's a small percentage. And so what we will find is that we as EMS providers will be exposed to a greater majority of them because we'll be called when most of them are violent and unmanageable. So the reality is that not most of them as what they believe. All right, so thank you. Moving along. So we mentioned before that gonna be concerned with patients having psychiatric emergencies, and we just said it that a lot of the times we'll be called to persons who are experiencing this high level of violence and unmanageable. So safe approach to a behavioral crisis safety gonna be a big issue, and so you'll be called upon to use all of your management skills, all of your assessment skills. You'll be called upon with these emergencies. But the big thing, as with all patient assessment, you're gonna be start with your scene safety. So from you get the call, you should be thinking about safety. And again, most of you would be in this group of well, you are in the security field, but once you are assigned as an EMT, then your role become a medical person, and so you're not gonna go to the scene as a tactical person. So you must remember that, and your role should be, I'm assuming that's still based on your protocol. I guess you would determine that, but usually if you're assigned as an EMT to the team, then your role should be as an EMT, not to deal with tactics. So it's about ensuring that the scene is safe, and if you cannot make it safe, then you'll have to call the person who will make it safe. And in these cases, all of the time, it is recommended that you call for law enforcement, so they can be there to assist you in making that scene safe, and they will end up also be a witness for you based on what you have to do for these patients. So all regular EMT skills are used in behavioral crisis. Other management, Mr. Johnson, you can turn off your mic, please. Other management techniques are also involved. So you'll be called upon to use all of your assessment skills. So again, you will assess the scene first, make sure that the scene is safe, and you will make sure you find out what's going on. So ensure you communicate, know where the exits are. So you're gonna make sure that the patient is not between you and your exit. Make sure that you are between the patient and the exit. make sure you have your personal protective equipment. So your general patient assessment step, scene size up, is scene safety first, see what's going on, NOI, nature of illness, MOI. You must make sure that you ensure that you are protected yourself, have a definite plan of action. You must make sure you are firm and confident when you go on these scenes, especially urgently de-escalate the patient's level of agitation. So again, it's gonna come to communication skills, how you can verbally de-escalate the situation, calm the patient down. Most cases, that's what you'll have to do. Most of the time, you might not even have to provide any other care more than de-escalate and take the patient in. So calmly identify yourself, because these patients, depends on what is happening to them, they might see you as an enemy, and so you have to try to reach out to them, that they recognize that you are not there as an enemy, you are there to help them. So it's all about how you deal with these patients and this situation, which will help to make it de-escalate it, or you might end up escalating it instead of de-escalating. So you will have to make sure you use all your assessment skills there, but make sure safety will be the first thing. So be direct, be prepared to spend extra time. So again, most of these calls you will be doing a lot of talking. So go ahead, Mr. Johnson.
Yes, boss. As you say, safety first. You see, what
Yes.
kind of sedative drugs you can use to knock out one of them patient? Boy, in tiny desperate times call for desperate measures in a boss.
No, well, you're not gonna go to drug first, so that's not a question I'm gonna ask right away, Mr. Johnson. A drug's gonna be a last resort, and you as an EMT will not be administering any drug to calm the patient. So you hear I said before, the first line gonna be verbal de-escalation. So you will have to talk to the patient first to de-escalate the situation. If you have judged the situation and recognize, manage it. Remember I said safety first. So you will assess the scene, assess the patient. If it's a patient you think you can approach, you approach. And I said before, you will have to bring your call for law enforcement if you think all the cases can escalate to that point. So have law enforcement there and work with them. If you think you cannot approach a patient, let them approach and then you go with them. So you think you can talk to the patient, you go and talk to them. Verbal de-escalation first. If that doesn't work, then you will take it to the next level, and it's all about your protocol. Guided by your protocol, it will tell you that you can go to the next level. If the patient is a danger to themselves and to others, to you, then you can go to physical restraint, and we'll talk more about that. If that doesn't work, then you will consider chemical restraint, but it's based on your protocol, and it's not you gonna provide that chemical restraint. So the drugs they're gonna be using is some form of sedative, benzodiazepine or some other antipsychotic drugs. But again, Mr. Johnson, it's just for information's sake, but you're not gonna be the ones to provide that. So that's why you have to take the patient in where they will get that. Or if your protocol covers, then maybe the medical director in your company will be the person coming to do that. Or in other jurisdiction where you have ALS gonna come, or paramedics, then they can provide that. Okay, Mr. Johnson?
Yes, sir.
All right. But we'll be talking more about the physical restraint, and we just mentioned chemical restraint, but it's not drugs that you're gonna provide out there, and that's not gonna be our first line of action. So be direct, be prepared to spend extra time. So again, these calls, you must know that you're not gonna be focusing on the 15 minutes that we say for a medical patient to be unseen and be on off the scene with the patient. So these patients, you're gonna have to be talking to them, talking them down, and you might have to be spending a longer time. So bear that in mind and know that you're gonna use your communication skills most of the time to de-escalate this situation. Stay with the patient, so don't leave the patient unattended unless it is for your safety. So one partner must be there with the patient at all times, unless it's become a situation where your life is, you are in danger, then you will have to take away yourself. But do not get too close either, because again, the patient can get violent at any point, and so you must know you have your space, and also the patient might consider you encroaching on their personal space, and based on what is happening, they might consider you as an enemy. So don't get too close, express interest. So always try to reach out to that person, be empathic, try to understand what they are saying. Not gonna go down a long road with them, let them lead you down into a dungeon, but you're not gonna try to fight them against what they are telling you either. So avoid fighting with the patient. Be honest and reassuring. So empathy is what we'll have to use. Put yourself in their position. Recognize that we said it's not that they made themselves sick. It is a problem that they are having. They have been overwhelmed by situations, and so they are acting this way. So do not judge. At the end of the day, don't be judgmental with these patients. Recognize they are having a crisis, and we are here to help them, not to judge them or to make their situation worse. But at the end of the day, at the same time, don't let them carry down a road that you're not having any way of coming back out from. So as we look at patient assessment, recognize that we said safety will be the biggest item there. If you cannot make the scene safe or you don't consider it safe, make sure you have the personnel, and it's gonna be law enforcement is your first line of person to help you with those cases. So ask yourself, is the situation potentially dangerous for you and your partner? Either it is dangerous or has the potential to develop dangerous. All of these cases, you are going to tell yourself that they can. So be aware, always have that situational awareness. Do you need immediate law enforcement backup? And again, I say, better to err on the side of caution. From you get that call, recognize that it has a potential, even if they don't tell you that the person is that violent at the moment, but better to have law enforcement there and you don't need them than you go there and you need them and then you have to call and wait for them to come. And again, like I say, most of you in this group are in the security field, but recognize that you are not gonna go there in that field, in that role. I'm assuming that your protocol would tell you that you are going as a medic, not as a tactical person. So again, it's based on your protocol, but usually that's how it is guided. So should you stage until law enforcement personnel have secured the scene? That's a decision you have to make. Does the patient behavior seem typical or normal for the circumstances? And again, it can seem typical, but has a potential to develop. Once a person having a behavioral crisis or psychiatric emergency, it can change to the worst at any time. So you have to be aware of that. Are there legal issues involved? And all of these, every patient care can become a legal matter. So, but especially these cases have more potential of having legal issues. So ensure that you take those into consideration. A person having a behavioral crisis, they have their rights. Once the person is competent, they have the right to refuse you from taking them in. But again, it's gonna be guided by our protocol, because a person is having a mental issue. The question is, are they competent to refuse care? And that's where you have a gray area, because these persons who will determine whether they were competent or not when you forcefully restrain the person and bring them in, and they come around and sue the company or sue you. So you'll be taken to court, and the court is the one who's gonna judge it, and that's where the gray area come. But most of the time, we're gonna err on the side of caution. The society or the legal system will protect you if your action is in the best interest of the patient. So once the patient have becoming a danger to themselves or other, or the provider, then you will have legal recourse to take action. And also, if they have a life-threatening illness or situation that you think is causing them to behave in this way, then the legal system will protect you to take the necessary action to give them the help that they need. But again, it's a gray area, so follow your protocol and accordingly. So as we look at scene safety, you're going to ask yourself the question, does the patient's behavior seem typical or normal for the circumstances? Are there any legal issues involved? Crime scene, consent. So once it's a crime scene, you know that it's going to have legal implications. So make sure that you the right thing. And also, if the patient has the right refuse consent, you have to take that into consideration. So know your protocol and do what is best for your patient. At the end of the day, you'll be covered even by the Good Samaritan law if your action were in the best interest of the patient. But follow your protocol. Take standard precaution and request additional resources early. So again, I say here on the side of caution, call for the law enforcement backup, because you know that these situations can develop into where you need them. So make sure they are there from early rather than late. Better they come and you don't need them and they go back, rather than you need them and you have to be waiting. So scene safety, scene size up is very big, and scene safety is the biggest item you need to make sure scene is safe before going to it. Mechanism of injury, nature of illness. So determine what is happening. A person having a behavioral issue, they can be from, most of the time it's gonna be on the medical side, but they can also have trauma with it also. So look at it and don't have a tunnel vision. Be open-minded and do your assessment and take it, see where it leads you. Note any medications or substances that may contribute to the complaint or be treatment of a relevant medical condition. So a patient taking medication, it can affect them, causing them to behave in this way, and also it can be affecting other medication interaction. So again, note it and make sure you're taking the medication, because the physician who's gonna continue care will need it to see, they will better able to use it to see what they need to do for this patient. So once you have covered your scene size up as you would do in all scene, but just remember with psychiatric emergency, a big focus gonna be on safety and how you gather that information about the scene. And also your primary assessment will be the same way. You're gonna start with your general impression, and most of the time you might not be able to go right up to the patient. And again, we say keep your distance, make sure you have your space, patient give them space also. So you might have to begin your general impression from the doorway or from a distance. Perform a rapid physical exam. So look and see what's going on there with the patient, and we can use look at their activity level, look how they are talking, and listen how they're reacting. Observe the patient closely using the AFPU scale to check for alertness, and we all know what AFPU is already. So establish a rapport with the patient. So once it is safe, then you're gonna start the talking process, because this is the big item that gonna use in these cases. So get the general impression, look at the LOC, and we have an acronym that we can use to assess these patient mental status. I don't think we have it in this side, but just for reference, it's called COAST map. So you're gonna look at their consciousness, their orientation, their speech, their still hear me?
No, sir. Could you repeat the acronym again?
COAST map.
Okay, COAST map.
So it is consciousness. You look at their consciousness, which will be their AFPU. You're gonna look at their orientation. You're gonna look at their speech. You're gonna look at assess their thought process, and check their memory. You're gonna look at their affect and their perception. So this acronym will help you as to assessing their mental status. So you will establish a rapport with the patient. So again, you will go through your ABCs just the same, but it's the big item gonna be talking to that patient. If they are in a state where they're agitated, then you have to de-escalate them to the point where you can continue with your assessment. Some cases you might not even go any further based on what is happening, but you might have to just go to your restraint protocol and try to get them to that point. So wherever possible, then you will move to your airway breathing circulation once you can safely do so. And again, ABCs are the big item for life threat, so assess them airway, make sure it's patent and adequate. If you don't have an airway, you don't have a patient. Evaluate the patient's breathing, use pulse oximetry if available. So do your regular ABCs check and see where it leads you. So for circulation, again, normal patient assessment, assess for pulse rate, quality, and rhythm, check for presence of bleeding, because there, as we said, you can have trauma situation, so check for bleeding and check for shock and evaluate for skin color, temperature, and capillary fill. So your normal patient assessment will be done in all patient care, but you just have to be focused on certain areas as it relates to psychiatric emergencies. But your normal patient assessment will be done in all cases. Just recognize that some of these patient population, depending on what you are presented with, you might not be able to go to do all of these checks. But as soon as the patient is de-escalated to the point that you can reach up to them, then you will always do your ABCs. And once you have finished your ABCs, then you're gonna reach the point that you're gonna make your transport decision. And if there is a case where you have to do a rapid scan, you do your rapid scan and then prioritize your patient. So unless the patient is unstable from a medical problem or trauma, prepare to spend time with the patient. So most of the cases with these population psychiatric emergencies, you will be dealing with talking to that patient to get them to the point where you can have a more better understanding of what is going on and see if you can get them to come with you for the help that they will need. Most of the time, it's not a situation where you don't have to treat anything in the field, but don't have that tunnel vision. Some cases we say it can be from low blood glucose, it can be from hypoxia, it can be some problem that we can treat in the field. So make sure where possible and you can do your assessment and recognize what's going on, then you will provide the necessary treatment. So once you have completed your proper primary assessment, get your general impression, get your LOC check, and we say we can use that course map as a guide to get your mental status of the patient. And again, that's gonna be a lot of talking involved. Then you would do your ABCs, assess and treat any life threats, and then prioritize the patient. If you need to move because of the patient having a threat to life or unstable, then you have to package and move. If the patient is in the state where there is no life threat, then you need to reach the point that they're gonna talk to that patient, get them to the point that you can treat them, and it's gonna be getting history. History gonna be a big thing with patients having a psychiatric emergency. Is the history gonna lead you in the direction of you have a better idea of what is going on? So history is very important. Investigate the chief complaint and obtain a sample history. So the chief complaint first, history of present illness, and you can use your OPQRST as a guide, and then you will finish with your sample history. So consider three major areas as contributors. Is the patient's central nervous system functioning properly? Are hallucinogens or other drugs or alcohol a factor? Remember we said that the patient can take mind-altering drugs that can affect them to be behaving this way, cause them to be behaving this way, or it can be a significant life-change symptom or illness involved. So we say stress is a big thing. Anxiety disorder is a big thing that can set up the person to be having this psychiatric emergency or behavioral issue. So you have to ask all these questions. So it's gonna be a big test of your communication skills, your history-taking ability. And so you have to spend time, and over time you will be able to master that experience, get the experience so you can go through it better. So as part of your history, sample history, you may be able to elicit information not available to hospital staff. So remember, we are the eyes and ears of the physician when we are out in the field. You are the first person to make contact with the patient in that case, so make sure you get as much information as possible. So when you're taking that patient or when you're giving your radio report, you can tell them what's going on so they can better prepare for that patient they are coming in with. So in geriatric patient, consider Alzheimer's disease and dementia. So the older population, that's a risk factor, set them up for these diseases. So your assessment has two primary goals: recognizing major life threats, reducing the stress of the situation. So use reflective listening. So listen to your patient, let them tell you what is going on. Don't try to go against what they're telling you, but at the same time, don't let them lead you down into a road where you can't come back from. So remember, but don't resist them to that extent. Just try to understand what they're saying and sympathize with them, empathize, and recognize live threat, treat live threats, and then you focusing on understanding what is going on and try to get them to the point that they can come with you to get definitive care. So we see some of the questions that you need to ask. So make sure you ask the relevant questions. So does the patient appropriately answer your question? And we say you're gonna look at all those thought, how they talk to you, their memory issues, if they have any memory issue, their mood, and their perception. So again, we will see that these emergencies are situations where persons are, they have lost touch with reality. So they are in a world by themselves. So you need to talk to them and hear what they are saying. So does the patient seem to understand you? Is the patient withdrawn or detached, hostile or friendly, happy or depressed? And so these answer you get from these questions will even indicate you the potential for violence. Are the patient's vocabulary and expression what you would expect under the circumstances? Does the patient seem aggressive or dangerous to your other? And then you will make your decision if you're gonna move to the next level. If you cannot de-escalate the situation verbally, then you have to move to your physical restraint. Is the patient's memory intact? So check orientation to time, place, person, event. What day is it? What time is it? What's their name? Who are, let them tell you who they are or who you are, if they recognize that you're EMT there to help them. And also what is happening to them. You know, listen to what they are saying and see if they're having any memory issue. Some of these population will try to make up memory to suit their situation, or when they can't remember things, they will try to create some memory. So listen to them keenly. You have to be a very keen listener. Does the patient express disordered thoughts, delusions, or hallucinations? So all of these will indicate to you, give you an understanding of what is going on and help you as you try to de-escalate and get a better picture of what is going on. So physical examination, again, it all depends on the level, how the patient is reacting. So if you're possible, you can do your physical examination. In an unconscious patient, begin with a physical exam. A conscious patient may not respond to your questions. So again, each situation you have to deal with it according to how it is presented to you. So remember, you might not be able to physically assess that patient, but where possible, you attempt to. And if you have to physically restrain, then follow your protocol and be guided accordingly. And again, law enforcement, try to let law enforcement assist or let them initiate it, and then you can take over. But be guided by your protocol at all times. Can you hear me still? Raise your hand if you are still hearing me. Okay. Physical examination continues. So you can tell a lot about a patient's emotional state from physical expression, pulse rate, respiration. So person elevated heart rate indicate that they are going through some stress. That's normally a normal reaction. The sympathetic nervous system comes into play and they will have increased heart rate. They're gonna have increased respiration. So look at those things and look in the patient's eyes. A blank gaze or rapidly moving eyes can mean central nervous system dysfunction. So assess these patients, and again, it can indicate you whether these persons are having the potential for violence. So a patient who is sitting at an edge, tense, jerky movement, be aware that that person might be getting in that position where they can become violent. So very important that you're gonna use all your assessment skills to assess these patients. So again, your transport decision is very important. Again, you would have decided from your end of your primary assessment whether you need to move right away. But if you had stayed with the patient, then you will at some point decide on how you're gonna transport your patient. So again, depending on the situation with your patient, if you have de-escalated the situation and the patient is calm, then you might decide to go with the patient by yourself, take the patient with you. But if you figure out the patient at the stage where you need help, then either you have reached the point that you would have physically restrained the patient, or the law enforcement personnel physically restrain the patient, then they would either come with you once the patient is in a handcuff, then one person with the key will have to ride with you, should ride with you, or if the patient is not having any medical condition that you have assessed, then you can allow the patient to go with the law enforcement personnel in their vehicle, but be guided by your protocol. So have law enforcement or firefighters accompany you if possible. Is there a specific facility to which patient with a psychiatric emergency are transported? And again, that's dependent on what is available in your area. So in Jamaica setting, we might just have to go to the nearest hospital and hope that they will have that psychiatric care that can be provided, or they will have to transfer the patient from there. But again, it's what's available in your area. But normally you'd want to go to the facility that have psychiatric emergency capabilities. So transport by ground, most of the time, if a person is that violent, it's not really safe to transport by air. So it all depends. Some patient might have medical issues that will benefit from air transport. So make the patient comfortable, and most of the time you'll have them in the forward position or high forward position. If they are restrained, then you will have them in the supine position or the left lateral position. So make that decision based on your protocol. So never let your guard down in when it comes down to reassessment. So you have the patient in the ambulance with you, whether the patient has been de-escalated or they have physically restrained the patient, never let your guard down. If you have physically restrained the patient, some patient will tell you that, I'm all right, you can release me. But that's when you should be even more aware. Again, we say they can be just pretending, or they can change at any point. So normally, once you restrain a patient, you should not release it until you reach the hospital with them. So never let your guard down. Many patients will act spontaneously. If restraints are necessary, reassess and document every 5 minutes. So you have placed a patient in restraint, make sure you're gonna check their extremities, especially that are being restrained. Make sure you still have proper PMS. Make sure the restraint that is not compromising their PMS, and check their respiration. I guess these patients can be prone to have cardiac issue because of the excessive agitation that they are going through. So make sure you are constantly monitoring your patient. Every 5 minutes, you're gonna need to reassess these patients. Go ahead, Mr. Johnson.
Right, trick it to the boss. Tell us say it's tight and them a feel pain and I'll bite you when you come near them and general them.
Yeah, that's definitely true. So again, we say be aware of your situation and be aware of the fact that the patient has that potential. So again, for your and don't let your guard down. That's the bottom line. All right. So again, we're not gonna be judgmental, but be aware of your situation, and safety gonna be foremost. So if the patient become aggressive or they're having any violent attack towards you, then you have that within your right to defend yourself with reasonable force. So you're not gonna go overboard, and especially the security personnel here come with your tactical skill and just knock down that person. But you're gonna use the reasonable force that is required to defend yourself and de-escalate the situation. Go ahead. Who is that again? Go ahead.
Sir, what if it's
Who
a
had their
good
hand up?
morning again, sir? Wellington, sir, good morning again. What if it's a case where you are called to a scene, right, by a family member, and they told you that this person is behaving aggressively, and when you go on the scene, the person is calm and seems cooperative? I heard you were saying that based on communication, when you try to reason with the person, if it seems that you are capable of moving in, you can do so. But what if when you got the call and the family said to you that the person was violent, and when you go on the scene, it is different? Do you think it is safe for you to move in to deal with that person?
Okay, Miss Wellington. So as I said before, you're gonna start from beginning. So every patient care start with patient assessment, scene size up. So you get a call and that's what they say. So you're gonna have it in your head that yes, the person was violent. They say the person is calm now, or you know that the person have the possibility or the potential to become violent again. So you're gonna go with that impression and you're gonna size up the scene when you reach there. If when you reach there and you can see the patient from where you reach, then you're gonna start your assessment. We said that you're gonna do your doorway assessment or from a distance. You're gonna try to. Are you hearing me clearly? Raise your hand. Can you hear me clearly? Okay. Okay, Miss Wellington. So you will assess the situation when you reach on the scene, and we said that you're gonna look at everything pertaining to the patient, their position, if you can start talking to them or they talk to you. So you will have to assess that situation when you reach there. And your assessment, you will have to make a determination. Can you hear? Can you hear me?
Sir, you're breaking up. I don't know. It shows that your net is low. I don't know if you could refresh it.
Okay, 1 minute. Are you hearing me now?
Yes, sir, better.
Okay, so back to that answer, Miss Wellington. Remember, you will do your assessment on the scene, and based on your assessment on the scene, you make that determination if you can approach that patient. So it's all about your assessment when you reach on the scene, not from what they told you. You use what you get from dispatch as a guide, but once you reach on the scene, then you make determination. And again, we say, if you assess that scene and say that you consider you can approach that patient, you're going to approach, but we said that you will make sure that you have know your exit. If the person is in a room, then you will make sure you are between your exit and the patient, not the patient between you and your exit. And you're going to be having that constant ongoing situational awareness, recognizing that this scene can become unstable or violent can develop. So you will have to be monitoring your patient. We said looking at the patient, to how they're talking, looking in their eyes, you can judge the potential for them to develop that violence. You might not be able to have it down to the T, but you'll have to make a determination if you want to go in there. And again, we say have law enforcement here with you, so assist you. Again, for the person's security personnel, remember that you are there as a medic. So again, follow your protocol. You must know if you are going there as a dual role tactical person or a medic solely. So make sure you have the law enforcement to assist you. Okay, Miss Wellington and class, that answer the question?
Okay, sir.
All right. So as we continue with reassessment, you're going to look at your interventions. So whatever you have done patient, you're going to look back at it in your reassessment. So if the person had life-threatening situation and you have provided ABC treatment, if you have given oxygen, you're going to check back on the tank, make sure oxygen is still flowing. Whatever intervention, if a trauma is involved, then you're going to check back to see if you're controlling the bleeding. But there is often little you can do during the short time you will be treating the patient. And if the patient is restrained, we say that you will make sure that the restraint does not compromise their PMS. But again, most of the time with these cases, these calls, it's gonna be talking, communication, and you have to reach to the point that you have to physically restrain. You'll be transporting them in that position and keep talking to them, keep monitoring your patient, diffuse and control the situation. And we say, don't be fooled by them when they become calm and say that you must release them. Make sure you keep that on until you reach there at the facility. Safely transport the patient to the hospital. If you think a pharmacological restraint is necessary, request ALS as early as possible. So Mr. Johnson, you asked a question about what drugs. It is not you gonna give the drugs. So remember, if the physical restraint is not working, some patients, especially those who are on PCP, patients who are very aggressive, very violent, very unmanageable, the physical restraint might not be sufficient. So that's where you're gonna move to your chemical restraint, and that's where you're gonna come with your drugs, so your sedatives, your antipsychotic medication. But we say it's not gonna be the EMTB that is gonna provide that. It's gonna be ALS backup, or depends on your protocol. If your medical director is gonna come and see and provide that, or whoever gonna provide that from the advanced side, then that's where it will be done. Or you just have to take the patient in as best as possible, making sure you are looking out for your safety. And if you have to use reasonable force to protect yourself, then that is allowed, or you'll be covered. But again, it is reasonable force. And with this population, try it as best as possible. Make sure you have a witness. If it's two of you on the team, if you can get the law enforcement personnel to ride with you, or make sure you have a third person to ride as a second person in the back of you, then it will help mitigate legal issues. We're going to touch on legal issues shortly. All right. So communication and documentation, I said before that communication and documentation is going to be a big issue with these patient population. So these cases have the potential to become a legal matter. So make sure you document whatever you did. Failing to document it, it's going to be said that you didn't do it, and it's not going to be there to help you when come to a legal matter or court case. And communication, we say, is where we'll have to be communicating with your patient. You'll have to communicate information to the receiving facility. Be thorough as best as you can with these cases. So give the receiving hospital advance warning of the psychiatric emergency. Let them know what they're coming in with so they can prepare themselves. If they need to get other additional personnel or specialists to be there, then they will get them. So make sure you tell them exactly what's going on. Document thoroughly and carefully. Yours may be the only documentation about the patient's distress. If restraints are used, say which types and why they were used. So you have to give account why you had to resort to restraint. You can't just come and just put restraint on every patient. We said it can have legal implication. The person have a right to refuse you taking them in. If you consider them competent and they don't have any life-threatening situation, legally you cannot do anything to force them to go with you. So follow your protocol. So as we are looking at the different types of emergencies, a person more than likely can be having a psychotic emergency. So this is where we said they are out of touch with reality. So they are in a state of delusion. So it's as if they are in a world by themselves. They are hearing things, they are seeing things, and they are going to be there in their own world. So it can be caused from mind-altering substances, intense stress, delusional disorder, schizophrenia. So this is where you're going to have a functional issue. So there is nothing physically wrong with the person. They are just going to be having these mental issues. So you have to be aware of that. So a form of psychosis is schizophrenia, and this is a complex disorder that is not easily defined or treated. So it is just a state of this delusion. The person is out of touch with reality. So they are going to be in a world by themselves. So typical onset occurs during adulthood. Influences start to contribute include brain damage, genetics, physiologic and social influences. So be aware of this, that this can be happening, but at the end of the day, it is what you are presented with that we're going to treat. So we not our job to diagnose exact cause, but it's to be aware that this can be happening. And so what they will present with in case of schizophrenia, they will have delusions, hallucinations. So these two are gonna be the big thing. They'll be talking all kind of things, that they are seeing things, somebody talking to them. So lack of interest in pleasure. So they're not interested in a partner anymore. Erratic speech. So they're gonna make their own words. What they see is happening to them. So when you're talking to them, their speech will be affected, because they're gonna talk some things that you're not gonna understand. So that's the situation. But do your assessment and get an idea of what is going on and take it from there. So guidelines for dealing with a psychotic patient: determine if the situation is dangerous. So that's a big item, the first item. Safety first. Clearly identify yourself. So you have to make them realize that they are gonna almost be seeing everybody as an enemy. So you must try to identify yourself and try to let them recognize that you are there to help them. You are not there as an enemy. But again, they might be so far out of reality that even when you tell them that, they still don't realize it. And so you must be aware now that they can be violent. So have that situation awareness. Be calm, direct, and straightforward. So you have to try to take charge of the scene, but at the same time, don't be overly aggressive. Don't force them to conform to what you're saying, but try to be direct and calm, and try to be reassuring and be empathic. Maintain an emotional distance. So these persons are very much aware of their space, and they are gonna see you coming too close. They might see you coming, consider they are coming to harm them and lash out at you. So maintain an emotional distance. And for your own good also, you don't want to get too close. So guidelines continue. Do not argue. So you try to get them out from the reality that they are in, but if they tell you that they're seeing some green men, tell them that it could be not really green men, but can be some shadow they're seeing. But if they insist, don't argue with them, all right? Because you're only gonna escalate the situation. Explain what you would like to do. So tell them, don't ask them, can you come with me to the ambulance? Tell them, I would like you to accompany me to the ambulance so we can take you to get help. So you have to be firm and direct, all right? But again, not to the point that you're gonna argue or aggressively force them to go with you, all right? Involve people whom the patient trusts, such as family or friends, to gain the patient's cooperation. So as best as possible, get persons who are not really needed there out of the area, but you might have to have one or two person there, family member that you think can relate to the patient to a level that they can trust them better. But maybe the patient might be in the situation to because of some family member, so you have to judge that situation, and you don't want somebody who is there that will make the situation worse either. So it's all about your assessment and what you think is the best way to handle it. So another form of mental health disorder is caused from excited delirium. So this is not this is more of a cognitive issue. So delirium is a condition of impairment in cognitive function that can present with disorientation, hallucination, or delusion. So it's not as severe as the psychosis, but it's having the way how they think, their thinking process is affected. So agitation is characterized by restless and irregular physical activity. So patient may strike out irrationally. Your safety must be considered. So with all of these behavioral emergency or psychiatric emergency, the underlying thing is your safety come first. So be mindful of it and try as best as possible to judge the patient reaction and see what the potential is and protect yourself at all times. So symptoms of delirium will include hyperactive irrational behavior, vivid hallucination, hypotension, tachycardia, diaphoresis, dilated pupils, and the last four there will be coming from this nervous system stimulation, the sympathetic response. So it's gonna cause the heart rate to go up. It's gonna cause the respiration to increase. Gonna cause the pupils to be dilated, and the skin gonna be cold and clammy. So you will see those signs. It's all a part of the reaction. But the main thing you're gonna see coming up is hallucination. So similar to psychosis, they're gonna have these hallucination tendencies. So recognize that it's what is going on. So be calm, supportive, and empathic. You're trying to gain these patients' trust. You can't be coming there as an aggressor. So try to get them to understand that you're here to help them and be calm. So you don't escalate the situation. You're trying to de-escalate the situation. Approach the patient slowly and respect the patient's personal space. We can't overemphasize that. It's for your own good as well as the patient. They don't want to see you just encroaching on your space. They might see you as a potential enemy. And you want to make sure that you have that space that you need to move if you have to move. And another thing you need to remind you also that and that can become a weapon or something that the patient can grab onto you, you need to remove them. So if you have your holster at the side with your scissors, better to remove the scissors. And if you have your ID and your pocket shirt, take it off. Anything that you can grab on or can use a weapon against you, need to remove it before you consider going towards a patient. Do not limit physical contact. Do not leave the patient unattended. And we keep saying that. So one person or both of you should be there at all times, unless we say that the situation become violent and you have to take away yourself. Then you have to move. Try to indirectly determine the patient's orientation, memory, concentration, judgment. And we said from your LOC check, you're gonna be checking those. So what is their LOC? If they are alert, then, and most of the time with these population, we said they won't have any physical issue. So it's gonna be alert, and you're gonna move to their orientation. That's the ones that are gonna be affected. They will have some varying degree of orientation, memory issue, concentration, judgment. So you're gonna look at these things and judge what is happening. Pay attention to the patient's ability to communicate, appearance, dress, and personal hygiene. We said that behavioral emergencies set up a person to have changes in their daily activities of daily living. So the person will maybe in some which we know when we say persons are mad, they'll be wearing the same clothes for days, months. So they won't be doing what society considered normal. So when you see these things happening, then you can recognize that there is some behavioral crisis going on or some psychiatric emergency. So we are to be advocate for a patient, and sometimes that's all we need to see how their living condition is, and we might have to refer to even what they call it, adult protective services based on your jurisdiction. So if the patient has overdosed, take all medication bottles or illegal substances to the medical facility. Again, we said that these can be used by the physician to see what is happening, because some medication can be the cause of what is happening to them, and medication can interact with medication to cause that reaction also. So it's very important that you note it for your record and also make sure you take it in for further care of the patient. Transport the patient to hospital with psychiatric facility. And again, we say what is available in your jurisdiction, you will have to use. Refrain from using lights and siren. So these will only agitate the patient more. Most time these patients are gonna be in a state of agitation, anxiety disorder, the hallucination disorder with the delirium. So remember, these situations, they need to be de-escalated, not escalated, and the lights and siren will set them up to become more agitated. So if the patient's agitation continues, request ALS assistance, so chemical restraint can be considered. So chemical restraint will always be a last resort. Verbal de-escalation is the first technique we'll use, and that's what we'll use at EMTB level. Also, physical restraint will be considered second. And again, use of law enforcement so that they can initiate it and you follow. If the protocol allow you, can go right ahead based on your assessment of the situation. But where possible, have the law enforcement as a witness, because they can witness to say, yes, you have the right to be using the physical restraint and you are doing it the proper way. Again, protect yourself from the legal implications that can follow. So it says here that uncontrolled or poorly controlled patient agitation can lead to the patient's sudden death. This is a thing you have to remember. I mentioned earlier on that the agitation, constant agitation, can set up a person to have these acid build-up and lactic acid build-up from the constant agitation, and it can cause electrolyte imbalance and changing them heart rhythm, so they can have cardiac arrest. So remember, that is why we say monitor them when you restrain them, because you don't want them to be in that, and talk to them, try to keep them calm. Can you hear me still?
Yes, sir, loud and clear.
Okay, so when we come on to restraint now, so you try to verbally de-escalate the situation and the patient is still getting to that point that they are still violent, they are still unmanageable, our protocol will cover us to move to the physical restraint. So every pre-hospital care transport provider should create and follow a pre-hospital patient restraint protocol. So your protocol, there's a general protocol for the country, but your service that they're working for will have their protocol. It should maybe conform to the country protocol, but they might have their own. So remember, know your protocol. So if the guiding point is that once the patient become a danger to you, themselves, or others, then it covers you providing that physical restraint. So it might tell you that you might have to have law enforcement there to guide you, or it might say you can provide it. Also, if the patient has a medical condition which you think is contributing to their behavior, then the law will cover you to take it to the next level to physically restrain them even against their will. But like we say, it's a gray area, so make sure you follow your protocol. So protocol vary through the country. So know what is available for your service and overall for the country. The restraint chosen should be the least restrictive that ensures the safety of the patient and providers. So whatever you have to do, it must be why you have to do it, is it needed, and don't be overboard with it. Just the proportion that you need to ensure your safety and the patient safety, and you're able to do what you need to do for the patient. So again, that's what they're gonna use when it comes to legal matter. Did you use the force that was required, or did you go excessive? And if it is that you went excessive beyond what you could have done, then you'll have to give account for that. So personnel must be properly trained, and once you're gonna do the physical restraint, you're gonna need 5 persons at a minimum. So 1 person for each extremity and 1 for the head. And you must have a leader, and you must decide beforehand who is gonna go to which extremity. It doesn't make sense when you go all 5 persons going to the left hand or the left foot or the head. So you have to decide where each person gonna go from beginning. So if you restrain a person without authority in a non-emergency situation, you expose yourself to a possible lawsuit. Make sure you note that. Legal action can involve charges of assault, battery, false imprisonment, violation of civil rights. We say that the person, every human being have a right to be free. So if you're gonna forcefully restrain a person without their consent, then make sure you have enough reason to be doing it. And the reasons we say gonna be, they have a life-threatening situation that need to be addressed and they don't want to allow you to do it, or they are being a danger to themselves, you or others. So make sure you are doing it for the right reasons. So you may use restraint only, and we said that already. So protect yourself, the patient, family member, or you may only use reasonable force as necessary. We said that before. Follow protocol. Must make sure protocol for your company. And if you're not sure, so any call you go on, your protocol, you have standing order that tells you what to do. If you are faced with a situation, and every situation will have their own uniqueness. So if you are faced with a situation and you're not sure about your standing order, that it covers what you should do, call your medical director and let them tell you how to proceed. And involve law enforcement if the patient is in a severe behavioral crisis or psychiatric emergencies. We can't overemphasize that. So make sure you are protected. Before considering physical restraint, use verbal de-escalation techniques. And we said that already. Ask the family member to assist you in calming the patient. And again, we say, make sure you are judge the situation, because some family member might make the situation worse if they are contributing to what is happening to the patient. So you must assess that also. Be honest and straightforward. Talk to the patient. Tell them what you are doing, what you need to do, and do what you have to do. Talk in a friendly tone. So we say, don't be judgmental. You're not gonna just dare to aggressively restrain the person. You are doing it for their own good. So talk to them in a friendly manner, and at the same time, you're trying your same verbal tactics at the same time. Process of restraining a patient. So once you decide to do it, you're gonna carry out the action quickly, not too quickly at the same time to let the patient get too anxious either. But you must make a decision and move towards it, and make sure there should be at least 5 people. We said 1 for each extremity and 1 for the head. There should be a team leader and plan of action. Use minimum force necessary. Level of force will vary depending on these factors. So the degree of force that is necessary to keep the patient from injuring himself or other. Just the force that you need to achieve that point. Not to say you're gonna cause any bodily harm to the patient. The patient's sex, size, strength, and mental status will determine how much force you need to use. The type of abnormal behavior the patient is exhibiting. And we say that certain patients and some certain drugs, they will not respond to this restraint physically, and you have to move to the chemical restraint. And again, we say that the more they're gonna be agitated, the more they're gonna set up themselves to get in that cardiac arrest. So you have to be mindful of it. Talk to the patient, show the process, treat the patient with dignity and respect. If possible, a provider of same gender should attend to the patient. So if it's a female patient, you have a female partner, let the female partner be the person initiating, and wear appropriate barrier protection. So some of these patients will be spitting at you. So if you need to put on your gown, your mask, your eyewear, protect yourself. Okay, avoid direct eye contact and respect personal spaces. So some patients, if you're staring at them again based on the level that they're at in their delusion or hallucination, they might see you as trying to get into their thoughts or some negative things. So avoid it if possible and respect their personal space. Never leave a restrained patient unattended. All right, we keep saying that. 4-point restraint, both arms and both legs are preferred, and you can use a restraint material, depends on what you're using. It can be cloth, leather. If you go to the extreme where you're gonna have law enforcement handcuffing them, or straps if your protocol allow you to, then whatever. But you might have to use your strap also to secure the legs and the waist, depends on your protocol. Whatever you need to get them to that point that you need them, and they'll be in. You're gonna restrain them in the supine position or the left lateral position. So monitor the patient for vomiting. Remember, we all heard about the case with George Floyd the other day in Minnesota. So if you restrain the person, you have to be aware that you can't restrain them, that they affect them airway, affect them breathing to the point that they're gonna have the positional asphyxiation. So remember that. So they must monitor them. Once you are restraining patient, you are responsible for them because they will not be able to do everything for themselves. So make sure you put them in a certain way that they can have fluid draining properly. Ear obstruction, you have to monitor it, and respiratory status. We said these patients in their agitation, they're gonna be tachypnea, tachycardic, and also they can have changed their level of consciousness. So make sure you constantly monitor your patient. You're gonna be responsible for them once you put them in that restrained position. So for potentially violent patient, make up only a small percentage of patients undergoing behavioral or psychiatric crisis, and we said that from the beginning. But we as providers gonna be faced with a greater majority of them. The fact that they're gonna call us when they reach that point. So normally, if they're calm and they realize that they have an issue, they will take them in themselves most of the time, especially if in Jamaica setting. They're not gonna call ambulance for somebody who is just walking around and not violent. So they will take them in, family or take them themselves. So most of the time we are gonna be called when they are unmanageable. So the potential for violence is always a critical consideration for an EMT. Have that situational awareness. So with these violent patients, whether they are currently violent or they have the potential, so has the patient previously exhibited hostile, overly aggressive or violent behavior? So in your history taking, make sure you're gonna take all of those things. Look at how the patient position, talk to them, listen to how they are talking to you, and recognize that you can realize that the person has the potential for violence. Their posture. How is the patient sitting or standing? Is the patient tense, rigid, or sitting on the edge of his or her seat? These are indicators of the potential for violence to erupt. So look at those things. Assess the scene. Is the patient holding or near potentially lethal objects? So be aware of that and make sure you take your necessary action. Vocal activity. Which kind of speech is the patient using? Talking loud. We talk about the speech that they create in their own words. Remember, that can be setting them up to become violent. So erratic, obscene speech pattern usually indicate emotional distress, and they can be violent or become unmanageable at any point. So physical activity, most telling factor of all. So what they are doing is a big indicator of the potential for violence. A patient requiring careful watching is one who has tense muscle, clenched fist, or glaring eyes, is pacing, cannot stay still, is fiercely protecting personal space. So recognize this, and that's what we said. Ms. Wellington, you asked a question earlier. If the person said they are calm now, how will you know if you should approach? Well, these are the things you're gonna look at to tell yourself that they have the potential. You're still gonna be deciding you're gonna go to them, but be aware that the potential is there. Get law enforcement to be there with you in case the situation escalates. And again, we say if they move at you, then you are within your rights to use reasonable force to protect yourself. But again, it's a reasonable force. So other factors to consider: poor impulse control, a history of truancy or fighting and uncontrollable temper. So if they give you the history so that they behave like that before, then tell yourself that they can behave like that now also. History of substance abuse, depression, functional disorder. So all these are factors you're going to consider to say that this person have the potential for violence. So another issue that a person can be having that set them up to have behavioral situation or psychiatric disorder is depression is the single most significant factor that contribute to suicide. So again, we say there's good stress and there's bad stress. Persons overwhelmed by the stress and they become depressed, and so they can resort to suicide. So it is a common misconception. So this is another myth, that people who threaten suicide never commit it. Listen to a person. If the person tell you that they are gonna commit suicide, they're gonna kill themselves, believe them. Don't tell yourself that they don't mean it. They are crying out for help. Some persons, yes, are seeking attention, but we don't know who is which one. So always err on the side of caution and recognize that if they say they are gonna do it, they can and will do it. So someone in a crisis that he or she cannot handle alone, we say that the situation is overwhelming them, and that is when we say it's become a behavioral emergency or a psychiatric emergency. So recognize that it can be like that they're gonna do it. Immediate intervention is necessary. So don't be judgmental. Don't write off a person. Be empathic. Put yourself in the person's shoes. Recognize that the person can be overwhelmed by some situation and they need help. Be alert to these warning signs: ear of tearfulness, sadness, deep despair, or hopelessness. Avoiding eye contact, speaking slowly and projecting a sense of vacancy, unable to talk about the future, suggestion of suicide, having any plans related to death. And so when you go on these scenes and you're doing your history taking, don't be afraid to ask them about these things. Sometimes we think it's not right to ask, or we're giving them idea. A person who has suicidal tendency is not a primary action. It is as a result of something that is happening in their lives. And we say they are overwhelmed by stress. That is what's going to lead them to the suicidal intention. So we asking them about it is not going to let them think about it. It's going to be, we have helping them. So ask them, are they thinking of, and one of the questions you can ask, do you think that life is not worth living? And you can start from there and build up to your other questions. You have any plan of killing yourself? You have anybody in your family do it, and all of that. So all of these will help you to see what's going on as it relates to suicide. So these are factors and you can look at them, but we mentioned some of them already. So a person have somebody commit suicide in their family, they can be prone to do it themselves. And we said that person having depression, they having divorce issue, bad news. So a whole host of things can set a person up. So you can look at that list and make sure you see some of the risk factors. Suicide. So consider these additional risks. So are there any unsafe objects nearby? Is the environment unsafe? Is there evidence of self-destructive behavior? Is there an imminent threat to the patient or others? So a patient who all of a sudden just make a will, think about the fact that they considering suicide. A person who just come and sell out all of them property, just start to sell off things, can consider that they are thinking about suicide. So just remember that these additional risks are things that you should consider, because if they have these things around, they can be thinking of using them or whatever means they need to. And somebody who tried to commit suicide and wasn't successful, they can go ahead to complete it. And so you have that person in the vehicle with you. That person, you come and stop them from doing what they wanted to do, they can attempt to do it right there with you in the vehicle. So they can try open the door and jump out of the vehicle. And also a person who is suicidal can also be homicidal, so they will take you with them also. So bear that in mind. So additional risk, is there an underlying medical problem? Are there cultural or religious beliefs promoting suicide? I guess we all know about mainly in the Middle Eastern region, you'll hear they have this belief that when they die, they will come back as with power, or their family member will get riches and all sort of things. So they be suicidal. So that's cultural. Has there been trauma? So trauma can set up a person to be getting these thoughts. So a suicidal patient may be homicidal as well. Are you hearing me okay? Raise your hand. Okay. All right. So this is an area that, well, not some of you in the class will maybe be exposed to it or more aware of. So post-traumatic stress disorder and returning combat veterans. So this is another big area that can lead a person to have these psychiatric emergencies. So PTSD occurs after exposure to or injury from a traumatic event. So example, a person who has experienced sexual or physical assault, rape victims, child abuse, serious accidents, war veterans. So these are situations that can set a person up to have PTSD, post-traumatic stress disorder. So they have been exposed to traumatic event or injury. It can have them to be reliving these situations and reach to that point that they have this constant thing affecting them. So examples are natural disasters, war, loss of a loved one, stressful life changes. These have a traumatic effect on the person, and so it can cause serious stress on them. So an estimated 78% of the general population will experience PTSD at some point in their lives. So again, we are saying it's not gonna say that you will have to have a psychiatric emergency from it, but it's a contributing factor. It can be reaching to that point that it become a behavioral emergency. So military personnel with combat experience have a high incidence. So you have gone to war and you have experienced some things there. You're exposed to near death experiences, and so it comes back to haunt you and you're reliving it, and so that can be a serious issue. And so symptoms will be helplessness, anxiety, anger, fear, and so these persons can become violent also. So recognize that they become overwhelmed and can cope with it, and so it can reach that point that they can be violent also. So people with PTSD, many may avoid reminders of the trauma and loud noises or smells, interactions with people. So they try not to be exposed to situations that remind them of what happened. So suffer constant nervous system arousal, can relive a traumatic event through thoughts, nightmare, flashback. So it can be a very serious situation. So combat veterans are prone to early heart disease. Again, we say it's because of the constant agitation, and that can affect their electrolyte balance and the heart rhythm. So it can set them up for heart diseases. Higher incidence of type 2 diabetes, loss of brain gray matter, higher incidences of traumatic brain injury. So this is related to the TBI, the traumatic brain injury, is related to the war veterans. They have been exposed to the explosives, and it caused, we talk about the different injuries that come from an explosion. So the blast wave injure the hollow organs, and so it can cause damage in the brain. So caring for combat veteran requires a unique level of understanding. Be careful how you phrase your questions. Use a calm, firm voice. Be in charge. Respect a veteran's personal space. Limit the number of people involved. Ask about suicidal intentions. So remember, they might not want to talk about it, but you can initiate it and get them to talk about it. And once you initiate it, they will be more than ready to get it off them chest. So have that listening ear, and remember, respect their personal spaces. Again, they might see you as an enemy and reliving that experience and can lash out at you. So it's all about be calm, be firm, but be in charge. Don't let them lead you down a road that we say it'll take a while to come back from. So, but don't be arguing with them. Caring for the combat veteran, ensure that there is nothing the patient can access and use as a weapon. So these combat veteran will most of the time have their weapons, so be aware of that also. So check your scene for scene safety at all times. Physical restraint may simply escalate the problem. So these are persons who have been well trained, and so you come in to restrain them, they're not gonna tolerate it, and so most of the time these restraints not gonna be effective, or gonna be matters worse. So these are the population that most of the time you'll have to call for the chemical restraint. So be mindful of that. All right, we come into the legal implications. Again, we say these type of emergencies, well, with every patient care, legal issue can and will always be a focus. So you must take that into consideration, but especially with this population, high ability of legal issues come into play. So you must make sure you know your protocols, the medical legal aspects of EMS, and you covered that in one chapter earlier on, are more complicated with patients undergoing behavioral crisis or psychiatric emergencies. So legal problems are reduced when the patient consents to care. So it is critical that you try to get that consent, and that's why we say you're gonna start the verbal de-escalation process first, because if you can get the person to consent to go with you or for you to treat them, then it will be easier for you in the long run. So we said it's a gray area because a person must be competent adult to refuse care, but a person having a psychiatric emergency, it's kind of can go either way. What I consider competent, another person might say the person wasn't competent. So that's a great area. If you are in doubt, call your medical control and let them guide you. So you don't want to set yourself up for any unnecessary legal issue. You must decide whether the patient needs immediate emergency medical care. So that's gonna be one of the underlying reasons why you're gonna need to restrain the person forcefully and take them in. Is it that they need to get immediate emergency care, life-threatening care that you think they need, and you have to restrain them? Or we say that if they're a danger to themselves, to you, or others. So the patient may resist your attempt to provide care. Never leave the patient alone unless we say you're in danger. Request law enforcement personnel to handle the patient. Again, we say your protocol is what will always guide you. Continue with medical legal consent or consideration. So consent, first thing we say, consent is gonna be implied if the patient is not mentally competent to grant consent. So just as though you go on a scene and somebody is unconscious, then we are gonna say that if the person was conscious, then they would ask you or agree for you to help them. So it's the same thing. The person is not mentally competent, then it is understood that they would agree if they were mentally competent. So that's a decision that you will have to decide. whether they were competent or not. So it's a gray area, but implied that they would if they were in that position. So consent matters are not always clear-cut in psychiatric emergencies. If you are not sure, request the assistance of law enforcement personnel or guide from medical control. Don't go and do something that will set you up for legal implications. You have your medical control there to guide you, but you should know what you can do within your scope and your protocol. Limited legal authority. So the EMT has limited legal authority to require a patient to undergo emergency medical care when no life-threatening emergency exists. So if you're in your judgment, there's no life threat, no ABCs issue, then you don't have any right to force the patient to go with you, unless we say the patient is in danger for themselves or others and for you. But that's the patient's right. So recognize that competent adults have the right to refuse care. But again, everything must be documented, and we say that try to have law enforcement there to act as your witness to say why you had what you did, one way or the other. So in psychiatric cases, a court of law would probably consider your actions in providing life-saving care to be appropriate. If a patient who is in any way impaired may not be considered competent. So a patient who is in any way impaired may not be considered competent. So that's what we say, the patient must be competent for you to allow them to refuse care. Maintain a high index of suspicion about the patient's condition. So you're always gonna err on the side of caution. Once you think that the person possibly having a life-threatening situation which is affecting them, then it is our duty to make sure we try to get them that help. Err on the side of caution, err on the side of treatment and transport. So the law will protect you usually if you are doing it for the right reason, but make sure you are doing it for the right reason. And again, if you are not sure, ask medical control to guide you. So we have come to the end of the first chapter, Psychiatric Emergency. A lot of information, some of you would be aware of, and we had some myths that we need to dispel, but we just need to ensure that we get these points. And so any question? Okay, let me ask a few questions as we get ready for a break. Mr. Let me see now. Okay, Mr. Wilson. What's the first tactics we will use to de-escalate a situation in a psychiatric emergency?
Sir, first that'll be fair. Talk to the patient or communicate with the patient so that them realize that you're not a threat to them. So keep them remaining calm and avoid that further agitation.
Okay. Mr. Thank you. That was Patrick Wilson.
Michael, sir.
Okay, Mr. Patrick Wilson. What's the second line of we will use to de-escalate the situation of the patient if verbal de-escalation doesn't work?
Okay, sir. After you get to know the patient and the situation, you'll ensure that there's no deadly force or threat around patient to damage you or that patient. So.
So what's the method you're gonna use? What's the next method if verbal de-escalation technique doesn't work? What's the next method you're gonna use to control your patient once it is required?
Again, the injections of
Mr. Patrick Wilson, you weren't listening. Mr. Johnson asked that question near to the beginning, and I told him that injection gonna be a last resort, and you as the EMTB will not be given any injection for restraint purpose. So, Mr. Manning, what's the next lever we're gonna use if the verbal de-escalation measures fail?
Yes, sir. So if the verbal de-escalation fail, we're going to proceed into the physical restraint.
Okay, good. And how many persons you're gonna need to physically restrain a person, Miss Wellington?
Sir, you will need at least 5 persons, 2 at the arm, 2 at the feet, and 1 to stabilize the head.
Okay, thank you. Mr. Zandre Powell, give me one reason why you would proceed to restrain a person physically. What would cover you restraining a person physically? Mr. Powell. Are you there, Mr. Powell? Can you hear me, class?
Yes, sir. Loud and clear.
Okay, Miss Rochelle, what's the reasoning for physically restraining a patient? What would cover you legally to physically restrain a patient? There are 2 main reasons. Tell me one. Okay, Mr. Powell, I saw that answer. Yes. Okay, Miss Rochelle, give me another reason. Correct. Thank you, Mr. Powell. Miss Rochelle, give me another reason why you would proceed to physically restrain a patient and you would be covered legally. Okay, like Miss Rochelle as this. Okay, Mr. Chantelope, can you answer that question for me?
Yes, sir. If there is a history of substance abuse,
Okay, but you would, if there's substance abuse issue, you would start with your verbal de-escalation technique, and if that fails, then something would cover you to proceed with your physical restraint. What other reason would be there to cover you apart from the patient in danger to themselves, you or other?
you're going forward to the patient, so you don't know if the patient is someone who is very feisty or someone who would like to fight. So here and then the restraint would come in.
Okay. Okay. And the person is telling you that they don't want you to restrain them. What would cover you to go ahead with the physical restraint?
You have to go in to do further checks, sir.
Say that again.
You have to go in to do further checks on the person, so you have to restrain them in order to get closer to continue your assessment, sir.
Okay. So your what would cover you is your suspicion that they can be having a life-threatening issue.
Yes, sir.
Okay. Go ahead.
Oh no, sir. The system was freezing up, so I was pressing to see if it works.
Okay. Okay. All right. What's the two diagnostic method the physician will use to assess the patient with psychiatric emergencies? Mr. Johnson. Hold on, Mr. Johnson. Go ahead, Miss Wellington.
No, sir, accident. Sorry about that.
Okay, Mr. Johnson. We mentioned two ways that the physician will use to diagnose the patient with a psychiatric emergency. We will be considering in our assessment. Two groups that we're going to place the disorders in. What are the two grouping? Mr. Johnson.
Yes, sir. So you said the two group.
Yes.
Yes,
we meant.
Are the one with suicide and Ptsd?
No, that's not the two grouping.
Are the one of the
We said that. Yes, that's it. So we said that as an EMT, it's not our job. Yes, Mr. Johnson. So functional is one, and the other one is?
Organic.
Okay, thank you. Any other question before we break take a 15-minute break? Any question you want to pose? All right. If no other question, we'll take a 15 minutes break. We'll resume at 10:50.